I'm going to start off by saying I'm even less of a researcher. I'm a registered nurse working in Sudbury in Ontario in an adult ICU, and I will give all of you kudos for working with children, because as an ICU nurse for adults, children absolutely terrify me. So kudos to you guys. Okay, let's get started. It's estimated Okay, thank you. It's estimated that in 2019, worldwide, over 347,000 people were diagnosed with a brain tumor. This statistic may not be accurate, as brain tumors are often underreported, especially when we go to non-malignant brain tumors. In Canada, 27 Canadians every day are diagnosed with a brain tumor. On October 9th, 2012, I was one of those 27 Canadians. You can see me here rocking my first ever IV. Let's talk a bit about brain tumors. Brain tumors can be classified by the following characteristics: origin, primary, so originating from the brain, or secondary in the case of a metastasis. By grade, 1 and 2 being low grade, 3 and 4 being high grade, and by the nature, either benign or malignant. The brain is a complex organ, and it controls many essential aspects of normal daily living. As such, multiple signs and symptoms can be caused by brain tumors. Out of the 8 most common signs and symptoms, I had 2: visual disturbances and frequent headaches, amongst quite a few more. There are no known causes for brain tumors, and brain tumors don't discriminate based on age, sex, ethnicity, or socioeconomic background. Due to the wide variety of ways brain tumor can present, signs and symptoms can often go unnoticed. It's often a seizure that'll lead to the diagnosis, especially in the pediatric population, where we have a tendency to minimize and dismiss their symptoms. People with brain tumors don't look sick. I've heard more than once, "You have a brain tumor, but you're so good looking." Or maybe it was, "But you look so good." Either or. Let's go over my story a bit. My symptoms started in June of 2012, right as I was about to get ready to graduate from high school. Mainly headaches and fatigue. I went to see my family doctor, explained my symptoms, and he ordered a CT scan. In July, I started noticing some visual issues in my left eye. I had the CT scan, and it came back as normal. In August, I went to see my optometrist. And after listening to my symptoms, examining me, and performing a thorough assessment, he couldn't find anything structurally wrong with my eye. He did mention that the issue could either be vascular or neurological. I'll let you guess which one it was. To give you an idea of what my vision was like at the time, if we look at this book right now, we can see the words and the individual letters. In my left eye, I could see that there were words, but I couldn't see the letters themselves. My vision was kind of pixelated. In September, I started nursing school. The beginning was nothing less than hectic. Not only did I have a purple roommate and a social life that was pretty active and could keep me up at night, whether I wanted to or not, the immense workload of nursing classes and the varsity swim team practices schedule definitely added to it. As September progressed, I noticed that my symptoms were getting worse. I was having more frequent and more intense migraines, more fatigue, physical weakness, and dizziness during physical exertion. All things could have been explained by stress, or from the workload of university life, or even from leaving my parents' place and living on my own. The only thing that could not be explained by stress was the vision loss. In October, more and more red flags were showing up. So my parents and I decided to go to the hospital. My vision had deteriorated from August to October. We can see here how the vision in the right eye was still perfect. But in the left eye, I had a significant loss in light sensitivity and an increase in blurriness. The changes in my vision were so gradual over months that it didn't sound an alarm. I was lucky enough to have an amazing doctor in the emergency room who took her time, listened to my concerns, performed a thorough neurological assessment, obtained a detailed history, and she knew something was going on. So she scheduled an MRI for the next day. If you don't know, it's quite rare to get an MRI for the next day, even in Grey's Anatomy. 5 out of 5 stars for her. The next day, after my MRI, another doctor came by. He told me, "We got the results from your MRI. You have a brain tumor." I know it's shitty news, but I'm on the phone with 2 hospitals to see who's going to take care of you. After the kindness and attention from the first doctor, the contrast in behaviors was staggering. I'm sure that as nurses, we've all had interactions with doctors that were less than optimal. But when delivering sensitive and critical news like this to patients, there are better approaches that can be used. I'm thinking of a very simple, structured, and effective SPIKES acronym. That moment, receiving the shitty news, as the doctor put it, shaped the way I approach and communicate with my patients and their families. This made me the kind of nurse I am today. Now, who says brain tumor? Says, game time. Let's play Find the Tumor. So this is an actual MRI of my head. It's the one that gave me the diagnosis. I'll give you a few seconds to find the tumor. Now, it's quite difficult to see this, to find the tumor without contrast. So let's add some gadolinium. Is that any better now? Let's go back and forth. Without. With. Let's add a grid to help you. Where is the tumor? The correct answer is B9. Anyone have B9? B9? No? Bingo? No? Just me. Okay. Kevin was about the size of a marble at the time of diagnosis. Who's Kevin, you might ask? This is Kevin. Kevin is a craniopharyngioma, a primary grade 1 non-cancerous brain tumor, one of the 120 different types of brain tumors. Craniopharyngiomas are histologically benign, but locally aggressive. They usually involve the pituitary stalk of the pituitary gland. To help you remember where the pituitary is in the brain, I like to think about it as the scrotum of the brain. As such, let's not be indecent. Let's talk a bit about craniopharyngiomas. They typically affect between 0.5 to 2 people per million per year. They make up 1.2 to 4% of all intracranial tumors. They have a bimodal distribution, most commonly affecting people aged 5 to 14 and 50 to 74 years old. They're classically very sticky and adherent tumors. They can affect the hypothalamus, the pituitary, and the optic nerve, explaining my vision loss. It makes them very difficult to remove, leading to a high reoccurrence rate of about 50%. Radiotherapy and radiosurgery can help mitigate the risks of reoccurrence. The good news, however, is that the 5-year survival rate is 83 to 96%, and the 10-year survival rate is 65 to 100%. I am so glad I'm in that last statistics. Some of you might be wondering, what does the pituitary do? I find that this comic from the Awkward Yeti really explains it well. It really shows how small but mighty powerful the pituitary is. We can see here that the pituitary is the king gland of the endocrine system. This system is intricate, and as such, having a tumor like Kevin can cause a wide range of signs and symptoms. About 40 to 87% of people with craniopharyngiomas will experience at least one of the hormonal deficits. I was lucky enough to experience them all. As you can see, being 6'1", I can tell you that my growth hormones were not affected. And typically for men, oxytocin is not essential. If you have any doubts, I will confirm to you that I do not have a uterus or ovaries, so we can take these out of the equation. If we add Kevin, we can see all the deficits he caused, bringing some of my hormone levels to near zero. However, my prolactin was increased to a critically high level. Their normal range for men range from 3 to 13, and for premenopausal women, 3 to 27. I was at 37. That is ridiculously high, so much so that in the first week of being diagnosed, I had an endocrinologist come by and ask if my nipples were lactating. As an 18-year-old guy, that is not something you want to hear. Thankfully, they did not. Let's do a quick review of the endocrine system. When we go to hypothyroidism, Kevin decreased everything. And when we talk about the thyroid not working efficiently, I want you to think about the metabolism slowing down. As such, some of these symptoms may appear: weight gain, slow speech, depression, forgetfulness, low energy, cold intolerance or feeling cold, bradycardia, hypotension, or constipation. Everything slows down. Hypogonadism occurs when there is low production of sexual and reproductive hormones. For men, low production of testosterone. The signs and symptoms are specifically post-puberty for men. Depression, anger, gynecomastia, increased visceral or abdominal fat, hot flashes, loss of muscle mass, low sex drive or low libido, testicular atrophy, erectile dysfunction, and osteopenia. Testosterone is well known for causing hair development, and as such, A lack of testosterone may cause sparse body hair distribution or a loss of hair that is already present. It puts a whole new meaning to the song from Shania Twain, Man, I Feel Like a Woman. When we talk about adrenal insufficiency, the adrenal cortex produces glucocorticoids like cortisol, mineralocorticoids like aldosterone, and even a small amount of androgens. The adrenal medulla, the core of the adrenals, will be responsible for the secretion of the fight or flight hormones, epinephrine and norepinephrine. Mineralocorticoids are only affected in primary adrenal insufficiency. As such, or just like in Addison's disease. As such, to the symptoms we'll see on the next slide, we can add hyponatremia, hyperkalemia, and even hyperpigmentation of the skin, giving the impression of a nice tan. In addition to its anti-inflammatory and immunomodulatory effects, cortisol supplies the body with glucose or energy in times of stress and plays an important indirect role in the fight or flight. The signs and symptoms of adrenal insufficiency can include low energy, bradycardia, nausea, vomiting, diarrhea, weight loss, increased craving for salty foods, muscle weakness, and increased insulin sensitivity, potentiating severe hypoglycemia. People with adrenal insufficiency may have a blunted fight or flight response. In acute episodes of stress, whether it's infection, surgery, trauma, or even when receiving an emotional news, these can cause an adrenal crisis, presenting with unexplained high fevers and severe hypotension that will be resistant or may be resistant to IV fluids and vasopressors. These patients will require stat IV corticosteroids to resolve this life-threatening state. ADH, or vasopressin. The hypothalamus produces the vasopressin, or an antidiuretic hormone, ADH, and it's stalked by the posterior pituitary, waiting to be released when needed. ADH causes the reabsorption of water by the kidneys, leading to decreased urine output and increased intravascular volume. In diabetes insipidus, specifically central, and with literature beginning to refer to it as arginine vasopressin deficiency, the decreased secretion of ADH will cause the kidneys to eliminate greater amounts of water, increasing the urine output significantly. Don't mix diabetes insipidus with diabetes mellitus. Diabetes insipidus has been referred to as a salty diabetes. People with diabetes insipidus will experience serious polydipsia, which is described as drinking more than 40 to 50 mils per kilo per 24 hours. For me, back then, this would have been about more than 4.6 liters. Polyuria will also be present, which results in urine outputs ranging from 5 to 20 liters. Some sources even going up to 40 liters per 24 hours. Before starting my antidiuretic, I could easily intake and output mil for mil 10 liters per day. And I'm sure that amount was higher before measuring. Until the antidiuretic is started, fluid or IV RPO must be maintained to avoid severe hypovolemia. This means letting the patient drink however they need to drink. The urine will be clear as water, mainly composed of free water containing very little sodium, resulting in hemoconcentration of the blood and hypernatremia. Those states can definitely be life-threatening. And fun fact, ADH is inhibited by alcohol. That explains why when people drink alcohol, they need to pee more often because there's a decrease in the production of ADH. Now, if we look at Kevin, the size of a marble at the time of diagnosis, and the amount of possible side effects it can cause, would you agree with me that these signs and symptoms would not be considered non-life-threatening or non-aggressive? Because non-life-threatening and non-aggressive is the definition of benign. This is why, and low-grade tumors can compress vital cerebral structures and cause as much disruption, complication, disabilities as a high-grade tumor. All brain tumors can cause mass effect, hemorrhage, seizures, and edema. The location of the tumor may have as much of an effect as the nature of the tumor or its grade, as it relates to the mortality and morbidity. The word benign to define a tumor undermines the experience and may result in dismissing the struggle that someone with the brain tumor has or will face. It may confuse the therapeutic approach, creating a false sense of reassurance about the prognosis and the clinical outcome. In 2021, the WHO classification of tumors of the central nervous system changed the term benign to non-malignant. I completely support their decision and encourage you all to keep the benign for bingo, because brain tumors are nothing to gamble with. Now, we've seen the impacts of Kevin. How do we treat it? Consider that prior to my diagnosis, all hormonal deficiencies could have been managed with medication, which could have indeed hidden the tumor, delaying treatment. This reinforces how important it is to have a clear picture of the patient and not to stick to treating symptoms. In my case, finding and treating the cause was the priority. After my shitty diagnosis, I spent a few days at the Ottawa Civic Hospital, being examined and preparing the plan of attack. I quickly realized that the food at the hospital was not as appetizing as it looks, and it already doesn't look appetizing. And a diabetic muffin for an 18-year-old who's not diabetic can really bring your spirits down. Thankfully, Tim Hortons came to the rescue more than once. If you have not gone to Tim Hortons, it's worth trying. It's a Canadian delicacy. I was discharged and told to wait for a call to schedule the surgery. I went home and kept up with my schoolwork until we got the date for the surgery. We headed to Ottawa, which is about 4 hours from where I lived, for the pre-op assessment the day before the surgery, to then be told that my neurosurgeon was outside of the country doing surgery, and that my surgery had been pushed back to next week, falling on Halloween. I can guarantee that in my first year of university, I was expecting different things to do on Halloween. They used the endoscopic transnasal transsphenoidal approach to reach the tumor. This is less invasive, and this operation lasted about 9 hours. Recovering was interesting. I quickly became bored staying in bed and trying to recover like a normal person, and was trying to do a few things to keep myself entertained, like wrapping my IV around an ice bottle to see if it cooled down the fluids, which it didn't. I also realized that recovery was not going to be as easy as I thought. Just sitting in a chair for the first few days was enough to drain the little energy I had for the day. I also discovered that the tube that was up my nose was a Foley catheter. The inflated balloon was used to put pressure on the operative site, preventing CSF leaks. I also had a lumbar drain, which could help maintain a certain level of pressure within my skull, also preventing the risk of CSF leaks. The day after my surgery, Movember started. And as I couldn't grow a mustache, because I didn't have any testosterone, I decided to reinforce the term mustache dressing. Humor, as you may have noticed, had an important place in my brain tumor journey. I went back to school 2 weeks later after being discharged from the hospital. I'm a big nerd. I really missed my social life and the possibility of finding a sense of normalcy in the chaos of the past month had been very motivating. Or it may have been a little bit of denial of the limits and refusing to accept the impacts and restrictions that Kevin had imposed on my life. Or maybe there was a part of it that was also me trying to protect my friends and family from the reality of the struggles that we were going through. Kind of a fake it till you make it approach. This also meant catching up on my midterms during the exam sessions, right before the holidays. The recovery wasn't easy, and I was having some unexpected and unexplained symptoms. There were moments where I would just start crying out of nowhere. I was having more migraines, and my vision was getting worse now in both eyes, and I was extremely fatigued. We thought it's going to get worse before it gets better, right? 2013 comes around, Happy New Year, new me, right? However, the red flags were back up. So we called my neurosurgeon and had an appointment the next day to see an ophthalmologist and to get an MRI. The ophthalmologist said something was going on, and then the MRI confirmed it. My neurosurgeon told me they needed an urgent surgery to remove a cyst that had formed at the operative site inside my skull and rule out an infection or a reoccurrence of my brain tumor. The next day, I went in. It wasn't a good feeling when other surgeries are canceled because of you, but it's reassuring to know that the doctors are willing and able to do it. This surgery lasted 5.5 hours, and they used the same transsphenoidal approach. This time, however, I didn't have a Foley up my nose, but 2 nasal packing drains. And warning, the next photo is of those out of my skull. So just looking at the size of the tube in relation to my nostril and then the packing, and looking at the size of the tube on the images of the tubes out, you can see they were quite big. And having them removed felt like I was having my brain sucked out of my nose. Quite uncomfortable. Then I was told immediately following this surgery that I would need a 3rd surgery. This time they would do a typical craniotomy and to access the tumor from a different angle. And as the tumor had indeed recurred. I received a date, but was delayed as my neurosurgeon was also out of the country. And I was told to go home, rest, and I would receive a date. I went back to school, trying to catch up as much as possible, waiting to receive the date for my 3rd surgery. Once I received it, I went back to Ottawa, and this time the surgery lasted 7 hours, about and a half, and it was an orbitozygomatic craniotomy. This also meant I didn't need to have a Foley or packing dressings up my nose. You gotta look at the good side sometimes. The recovery was more difficult, as expected since it was more invasive. Their main goal was to save the vision in my right eye, as it had affected my left eye to beyond the point of recovery. But I channeled my inner Rocky Balboa and kept fighting. My plans to head back to school were quickly stopped as the tumor was unusually aggressive and I was going to need radiation for 6 weeks. We couldn't afford to wait as the vision in my right eye could become compromised. So on February 11th, exactly 2 weeks after my third surgery, I began radiation treatment. I was started on a donut-like machine that was precise roughly to the centimeter for my first 5 treatments, which lasted about 5 minutes each. Then I was upgraded to the CyberKnife. This amazing machine was precise to the millimeter. And the upcoming, the downside, the upcoming 25 treatments would last about 45 minutes each. That is 45 minutes bolted to a table where you cannot move. However, it also meant that I could have really cool pictures like this one, where you can see a 3D simulation of my skull. I still had the staples on my skin from the third surgery. And the first thing I thought when I saw this was, wow, I have really nice teeth. On here, you can see the different beams they could have used, with the long, pale blue ones being the ones they used. They didn't want to use the red ones, as radiation in the eyes could increase the risk of cataracts. And here you can see all the beams they did use and the different sizes of beams. During the treatment, the machine would change the size of the opening to deliver more or less radiation. Radiation caused the tumor surrounding tissue to become swollen, causing further vision loss. I was practically unable to perceive light in my left eye, and the right eye was half blurred, making it very difficult to read. But I quickly learned that resting whenever and however became a priority. To give you an idea of what a brain with a tumor is like, I like to compare it to the brain tumor turning your brain into an old cell phone. It takes an eternity to charge your phone, and it rarely reaches 100%. And the battery doesn't last as long. So what? You're tired? No, I was exhausted. I had to budget where and when I would spend my energy and when I would recharge. But what if we add different treatments to the brain tumor? Let's start with some surgery to chop out the tumor. Maybe add some radiation to microwave the life out of that tumor. And if needed, sprinkle some chemo, which thankfully I never needed. Your brain has all the right reasons to be afraid. When you add all of these together, you get a phone that is way less than optimal, to say the least. This compares to not having a nice, accessible, and effective outlet, but having to bike to charge your phone, making you more tired as you go. The last day of radiation came around, and I got to ring the end of treatment bell. Well, triangle. I was kind of disappointed we didn't have an actual bell or a gong like I have back home. But I had my radiation team at my sides, and I rang the hell out of that bell. Those past 7 weeks had been extremely challenging for my parents and I. In the next few months, I recovered and then went back to school in September. Since then, I've reached quite some major milestones. Graduating, starting my career, buying a house, starting my own first aid, CPR, and BLS business, adopting a cat named Betadine, and starting in the ICU. But you never know what the future will hold. I never thought I would have been here talking to you guys, that's for sure. I want to make it clear that it doesn't mean that someone has a brain tumor, that they can't reach goals like these, but they may face extra hurdles, struggles, delays that won't apply to people without brain tumors. However, just like the same tumor, even at the same location, won't affect two people the same way, the sad reality is that sometimes these hurdles might be too high to overcome with a society that's not always able or ready to accommodate special and unique circumstances. My journey started 12 years ago and 5 days today. And I've been a nurse for 7 of those years. I learned many things having been on both sides of the stethoscope. The following section is based on my point of view, and I acknowledge that it might not be the same for all patients and all healthcare workers. Let's look at some of the priorities nurses and patients may have. For nurses, we'll focus on addressing and assessing issues in a head-to-toe fashion. Administration of treatments, whether it's medication, dressings, or interventions. Responding to emergencies and unexpected events that may arise. Document, and we all know how long this can take. Checking off to-do lists, whether it's forms, interventions, or daily scheduled tasks that you don't want to do. And repeating that for multiple patients. For patients, however, the priorities may be finances, from parking to hotel to loss of income, traveling, insurance, medication, home care, and so on. The cost adds up. Managing the mountain of information that we receive about the illness, the medications, the risk of benefits of doing or not doing a treatment, then dealing with the treatments and therapies and adapting or accepting the changes in the plan of care. All of this on top of dealing with the emotional, mental, physical toll of the illness itself. Not knowing what the future holds. Something as simple as when we'll leave the hospital to when lunch arrives, or when you'll go back to feeling normal, if ever at all. Juggling friends and family. When and how much information you'll give them, if any at all. Dealing with their reactions and emotions, sometimes more intense than mine. And the crossing of boundaries, which does happen. How the illness is going to affect, how the illness or long-term and residual effects are going to affect work and school. Both of these are strongly linked to both social life and financial stability. Not to mention the stigmas attached to returning to work or school requiring accommodations or the stigma of the illness itself. And lastly, being heard. It's quite difficult to be taken seriously or believed when ill or in a hospital bed wearing those ugly gowns. This may affect people's willingness to return and seek care in the future and affect the perception of what healthcare is and has to offer to them. Looking at these, many of our priorities do not align. Some actively go against one another. How can you take the time to hear your patient's concern when you have another patient that has chest pain? Maybe not for pediatric patients, but one wants a glass of ice water. You have an IV med to hang in another room. The IV pump is beeping in the other one. You're late for your morning documentation. It's 5 p.m. You haven't eaten, peed, or sat down since the beginning of your shift. I found one thing out of multiple things that can help assist your patients and their loved ones with these priorities. Listening. Even better if you can sit down. This is especially important with pediatric population, but all population. Sitting down helps decrease the power dynamics that strongly favor the healthcare worker. And it shows that you take your patient concerns seriously and that you'll make time for them. I want to emphasize the time of quality over the quantity of time. Other things that can help: being honest with yourselves and with your patients, and finding a way to be empathetic without sounding robotic. If you don't mean the emotion behind your words, the patients will know. It doesn't mean that they're ill, that they can't recognize false empathy. Something like, "Oh, I'm so sorry to hear about your very significant diagnosis. Have you been having regular bowel movements?" Does not work. And knowing your limits. I had one nurse, after I asked her a question, she said, "I don't know. Let's find out." She took out her phone, looked up the answer in front of me, gave it to me. Simple, but very efficient. If you don't know what to say in an emotional situation, something like, "I really wish I knew what to say to help you relieve some of the distress, the pain, or the worries you have." What you're feeling is normal. The last thing people feel in the hospital is normal. The very last thing. So whether it's naming your tumor Kevin, or it's crying about being diagnosed, or it's laughing about it, it's normal. It's normal for that person to react that way. And lastly, I believe you. By doing this, you communicate the limit of your ability to support the patient, but you're also validating what they're experiencing without becoming insensitive or faking your way with dishonest reassurance. Lastly, if you're feeling like you're becoming less yourself as a nurse, it may be a sign to step back and invest in some self-care, whatever it might be. A vacation, therapy, a massage, decrease your work hours, exploring other departments or work opportunities with other employers. You need to take care of yourself before you take care of others. Don't wait until you have a significant illness to realize this. You come first. You cannot take care of yourself before you take care. You cannot take care of others before you take care of yourself. My neurosurgeon had the biggest direct impact on my health, but they also taught me the impact of great bedside manners and how taking your time reflects a special investment in your patient. But you don't need to be a neurosurgeon or even a nurse to have a direct impact on someone. My radiation technicians, or my angels, they were caring and took the time to see how I was doing. I saw them every day for over roughly 2 months. That is more than I see most of my family members in a year. These check-ins went a long way to make me feel heard and supported. Or Jazzy, she was our waitress at Cora. She made me laugh on a particularly gloomy day and took the time to connect with us. She didn't know what my parents and I were going through, but she made a huge difference that day, and she later recognized us when we came back. She developed with us a better professional relationship in that little time we met than some providers with patients they've had for years. Jazzy holds a special place in my heart. Dealing with the long-term effects of the tumor and surgeries and radiation, along with adapting to the new normal, is often challenging at the beginning, but it's really a lifelong process. Since the end of my treatments, I dove headfirst into the brain tumor community, connecting with my fellow brain tumor warriors, patients, and caregivers from across the world, and leaning on them. Sharing our experiences brings a unique but relatable and much needed way to support each other, creating bonds like no other. I've been presenting mostly the good aspects of my journey and have used humor as a main coping mechanism. But believe me when I say it wasn't all funny, bright, and positive. We went through some very difficult and dark times. There is no denying. Those are moments that most of our friends and family didn't see. The kinds of moment we see in the hospital as nurses. But there's also the battles we fought outside the hospital. There's a quote that I like that represents this quite well. Happiness can be found even in darkest of times if one only remembers to turn on the light. You've probably heard me saying we or us. We went to the hospital, or she took our concerns seriously. We went through. That's because I was blessed enough to have amazing parents, Jean and Nancy Belec. They were at my side during those dark moments and my hardest battles. It wasn't just my tumor, it was our tumor. My parents weren't only the light, or weren't only the ones remembering to turn on the light, they were my light. My experience reinforced how essential it is for healthcare teams to include the patients and the family, whether chosen or not, in the circle of care. I've experienced firsthand the importance of having a support network to lean on and learned how humor can make dark moments a little easier. Without humor, social support, and especially my parents, my outcome would have been very different. I want to leave you with this. We can't control everything that happens in life, and controlling our reactions to this other absence of control can be extremely challenging. By acknowledging that and understanding that we don't know what invisible battles others are going through or have gone through, by having a kind approach and increased awareness to others' needs, we enable ourselves to provide support and motivation that someone may need at that moment to fight their versions of Kevin. After all, it doesn't mean that it's all in your head, that it's not real. It may just be your brain's way of revealing a previously unseen, more strong, more sensitive and resilient side of you. Thank you. Any questions? I'm an open book.
Sure. I just had a quick question about your post-op recovery while in the hospital. I mean, I guess which one, but as far as like management, did you go into, was your DI? Did you have to take like spot doses of DDAVP? Like, was it just mainly pain, things like that when you were in?
Awesome question. Yes, so after my first surgery, they discovered that like the surgery had triggered diabetes insipidus, and they started replacing everything. So thyroid, cortisol, the DDAVP for diabetes insipidus, testosterone was replaced a few months later because it's not essential. I strongly disagree with that. And I'm still on those medication to this day. After maybe 6 months after my radiation was done, I started having trigeminal nerve pain, which for a while I thought the tumor was back because why not a fourth time? And had the MRI, cleared that. So I was started on Lyrica for that, which works really well. and a few years later, play with your hormones and mental health will get involved. So I was started on medication to manage anxiety, depression, but otherwise the hardest recovery part acutely was the pain and just dealing with everything and trying to force my way through school, which when I was told I needed radiation, just went to the side. But yeah, the pain was there, yes, but again, the most acute part was just dealing with medication and managing the new normal. So I was just asked by the front, how am I today? I can obviously read. Yes, indeed. So I'm still blind in my left eye. And otherwise I've learned to manage the different situations as they arise, because I was dealing with school for like 4 years and adapting to like a new schedule and working with the accessibility services to help manage as much as I could. And it worked great. But again, it was managing the side effects that the fatigue was also very present. Like to this day, I'll wake up after a 16-hour sleep after a day shift, and I will be absolutely exhausted. Sleep does not seem to work for me to recover, but it is super essential. So that is one of the big things that's been addressed somewhat since. And yeah, medications, vision in the left eye, and like adapting to working at the hospital, like just managing everything that's expected from us and trying to provide competent care and not let my side effects kind of stop me, but also knowing that I may need to call in sick a few more times than other people, just because from one day to another, I could have a full-blown migraine and not be able to function. And I don't believe in putting my patients at risk because I want to go to the hospital and work, and putting extra work on my coworkers. And during COVID, it was stressful for all of us. And it was an added worry because one of my medication compromising my immune system. So the worry was very present, especially at the beginning when we didn't know if we should wear regular mask and N95s, anything in between. Yeah, good question.
Sorry, I had one more quick question.
Yes.
Your transnasal transsphenoidal approach the surgeon's approach, was it just neurosurgery or did they involve ENT as well?
If I'm not mistaken, there was an ENT involved to help patch up the hole. The first surgery, they use a part of my septum to plug the hole. And for the second surgery, they use a piece of fat to help kind of nourish that operative side that had been affected. And I was like, take some, I've got plenty to give.
Hi, Patrick. Thank
Hello.
you for that really beautiful and insightful presentation. That was really meaningful.
Thank you.
I'm just wondering if now you're so much more empathetic to all your patients that maybe you have more emotional burnout at work, especially given you're in the ICU?
That is an awesome question. I would say definitely for the empathy, I'm quite a bit more aware that I find than my fellow nurses. Whether it's while you're changing your patient, talking over that patient, because I've had that done after my first surgery. First bed bath as an 18-year-old, they just strip you completely naked and they rub hard with those awfully used towel that are rough like sandpaper. And they just talk together about another nurse that keeps going on break. Not the best experience. And just that loss of privacy, whether it's just shutting the curtain when you're like putting monitor on your patient, like just those little things I'm more aware of. I don't know if it's because they don't care or they're used to doing it that way. The empathy with my patients, I know what it's like to try to sleep and be waken up by code blue alarms or by carts going around or by nurses coming to wake you up to take your vitals or medications or blood pressures, and all those little things add up. Like try to recover from brain surgery when you're not able to sleep more than 2 or 4 hours without being waken up to be assessed. And I have to do it. And I know it's frustrating, but to kind of prevent that emotional burnout, I'll talk with my patient a little more. I'll be like, just so you know, I'll be waking you up at midnight and at 4 to assess you. Perfect. They're warned, they're not surprised. They're like, you'll have an antibiotic, I'll connect you, and then I'll have to come back after that to disconnect you. I'll try not to wake you up. Kind of giving warnings to your patients. And again, communication is a huge thing, and we don't have the time to do it properly. I'm lucky in the ICU, I have 1 or 2 patients. And if they're intubated and sedated, I'm dealing quite a bit with them, yes, but also with the family. So really asking some of the questions to the family, and I find I would probably be more burnt out if I wasn't doing that. But knowing yourself is important when it comes to that. I would not work with pediatric patients because I get way too attached to them. And if something bad happens or there's bad parents, I will become more involved in that than I should. And that's why I know I'm not going to work in pediatrics. I'm not going to work in emerge, not going to work in mental health and labor and delivery. Those are the 4 sectors that I would strongly not like to work in. And I'm lucky enough to work in critical care that I absolutely love and spend more time with the patients. So just those little things like talking at the nurse's station and the doors are wide open and all the patients can hear you. I know those little things, and I know how, just the food, like food, no sleep, not being able to shower when you want, having wires coming in and out of you, just all those things add up, and it affects the patient experience, and it's not something we can control, but there's a big part that we can control. And that's what I try to kind of focus on. Like, I'm not perfect. I've had my days where I did some of the things I didn't like having done as a patient. That might be the sign for me to take a break sometimes. It depends. It's really hard to say, but awesome question.
So time will encourage you to continue these discussions over lunch. Enjoy your break.